Welcome to Chapter 29, Bleeding and Shock for the EMT. So, just a quick overview of the circulatory system. So, we've got the heart that pumps the blood, we've got the blood vessels that move the blood around to the body, and then the blood itself, contained of plasma, red blood cells, white blood cells, proteins, and various other things that keep the body going. Okay, so that heart's job is to pump blood, supplies oxygen and nutrients to the body cells, and it must pump at an adequate rate and rhythm. Remember when we talked about shock or hypoperfusion? It requires that in order to maintain perfusion. Okay. And then we've got our vessels. So we've got our arteries, capillaries, and veins. The arteries carry that oxygenated blood away from the heart. They are thick and muscular, and then they also dilate and constrict. Our capillaries, these are microscopic. It's where the exchange happens with oxygen, nutrients, carbon dioxide, and all that stuff. And then the veins carry the oxygen depleted blood back to the heart, and then it gets pumped to the lungs, where the lungs exchange it out for carbon dioxide. Okay, so the functions of the blood: nutrition, excretion, protection, regulation, and transportation of gases. Okay, so those gases, oxygen, carbon dioxide, provides nutrition, provides all the proteins, all the various other hormones and things that are needed for the body to function. It provides excretion by filtering it through the kidneys. So all the blood gets filtered through the kidneys, and then the kidneys then excrete what it doesn't need, what the body doesn't need. And then provides for protection with the white blood cells. And then regulation, it basically says, hey, I'm not getting enough blood, so or this particular portion of the body isn't getting enough blood, so it's got to do that. Or dehydration, where it regulates the body's pH with either getting rid of fluid or bringing in more fluid. Okay. Perfusion, so this is that adequate circulation of blood throughout the body. Hypoperfusion is the inadequate perfusion of the body's tissues and organs. All right, shock. So this is the inadequate tissue perfusion. If it persists, the cells and organs are going to slowly start to die. Okay. So there's 4 causes of shock. There's volume problems, pump problems. It could be a blood vessel tone problem or an obstruction of blood flow. So we have here a perfusion triangle. You have to have 3 sides to a triangle. If you don't have 3 sides to a triangle, it's not a triangle, right? So all 3 of these have to be functioning in order for perfusion to exist. If perfusion doesn't exist, then, or one of these sides is missing, then we've got issues. Okay, so volume problems. You can have hypovolemia. This is blood that is lost. Plasma is moved from the circulatory system. There's not enough blood in the blood volume in the blood vessels, so our pressure fails. Both absolute and relative hypovolemia are called hypovolemic shock, and hemorrhagic shock is a loss of blood. Okay, so you could have absolute hypovolemia, which is blood loss, or relative hypovolemia, which is fluid loss, that we may get from like dehydration or various other things. Pump problems. So this can be caused by a failure of the heart to pump blood. It is usually related to a mechanical problem, not an electrical problem. And blood can't be moved because of a drop in blood pressure. This is also categorized as cardiogenic shock. Blood vessel tone problems or container problems. So all blood vessels dilate at the same time. If the blood cannot fill into the entire circulatory system, this is what's referred to as distributed shock. So we have a couple different types of distributed shock. We have anaphylactic shock, neurogenic shock, and septic shock. Anaphylaxis and sepsis is something that you will see on a fairly regular basis. Sepsis more than anaphylaxis, but neurogenic shock is one of those things that we won't necessarily see out in the field, but we need to be prepared for it, and it has to be treated before it even begins, really. Otherwise, the patient's just not going to make it. But neurogenic shock typically is not seen until 2 to 3 days after the shock to the body. We can have an obstruction of blood flow, so there may be some type of blood flow that is blocked. This is caused by a pulmonary embolism or cardiac tamponade or tension pneumo, where blood is not flowing, and this is obviously called obstructive shock. So remember our fight or flight response. So there's baroreceptors that stimulate the release of epinephrine and norepinephrine. These are normal hormones in the body. And what these do is constrict blood vessels, cool pale skin, sweaty skin. The kidneys start to produce less urine. You don't have to go to the bathroom. Nausea and vomiting also occur, and increased heart rate and contractility. This is also why in EMS, when the tones drop, you also have to go to the bathroom. It like never fails. It's one of those things. But this is a fight or flight response. The body is trying to get rid of anything that is not needed. And so what it does is it tells the bladder, hey, you need to get rid of this urine because I can't be thinking about this when we're doing this. So that's why the bladder gets rid of the urine. Or somebody gets scared and they pee their pants, same deal. This is that fight or flight response. So the body can compensate for so long and then it just stops compensating. So the body senses a decrease in perfusion and then tries to attempt to compensate for it. Sometimes, like anaphylaxis is the big one, the easiest one to use as an example. So in compensation for anaphylaxis, the body says, hey, I need to protect myself. So we're going to start dilating blood vessels. We're going to increase the heart rate. We're going to increase breathing because I can't breathe very well. We're going to protect our airway because I don't want anything to get into the airway. So it's going to start all of these things, and all of those things are compensating mechanisms, but with anaphylaxis, it can also be deadly compensating mechanisms. So even though the body's trying to protect itself and do all the things that it needs to do, it's a bad thing. Okay, but compensation ultimately tries to restore blood flow. So it starts to regulate volume. It does this by vasoconstriction or dilation. And then we have a cardiopulmonary response. We have an increased breathing rate. We have an increased heart rate. We get pale, sweaty because blood to the skin is not as important. And so we get all those things. And then compensatory actions collectively are called compensated shock. In kids, when you have kids, these kids will compensate, and then a 90-degree cliff downhill. These kids do not decompensate well, or like if you think about it, instead of a toilet spiraling down, they just go off this 90-degree cliff. So they'll compensate, and then boom, no longer compensating. They didn't even like have decompensation. It was just boom, I'm not compensating anymore, and I'm done. Okay. Compensated shock requires more fuel. And then when these muscles run out of that fuel for compensation, the compensated shock becomes decompensated shock. Indicators include a drop in blood pressure, mental status changes, slow heart rate, and slow respiratory rate. A drop in blood pressure is going to be your last thing that actually goes. So we don't want to necessarily wait for that. But that slow heart rate and respiratory rate are things that will occur early on in decompensated shock. So it's a good indicator that we've got some decompensation going on, as well as the mental status changes. That will also be one of those things that occurs early. So we have this spiral of death, where the patient goes into shock. They have compensated shock, and then they go into decompensated shock, and then they'll go into irreversible shock and death. When irreversible shock occurs, we also have what's called multi-organ death syndrome. So the body starts to, because it's trying to still compensate somewhat and protect things, so it's going to start shutting down organs. So heart, lungs, kidneys, and liver are all the last to go. So when you have irreversible shock and death and MODS, then all of this is going to start to kind of culminate, and it's really, really hard to get this patient out of irreversible shock, which is why we treat shock so early on. So when we assess these patients, you're going to try and identify the underlying problem. You're going to recognize that they may be in compensated shock. You're going to survey the scene for any kind of mechanism of injury or illness, and then you're going to do a primary assessment. Okay. In your primary assessment, you're going to look for ABCs, so airway, breathing, and circulation. Again, if I can correct any three of these problems, hey, I may be able to stave off the patient going into decompensated shock and further spiraling. You're going to treat any kind of problems found in the primary assessment, identify shock in trends and vital signs, so increase in blood pressure, increase in heart rate, increase in respiratory rate, pale, cool, clammy skin. All of those things are going to be signs of shock. Okay. We're going to identify any kind of conditions that are associated with shock. So if they're in anaphylaxis, they might have some hives all over the body. If they are in hypovolemic shock, depending on which kind, if it's fluid or blood, then we might have some type of bruising, or you might have an open wound that is actively bleeding. So you've got to take care of those things. Okay. And then your secondary assessment, do a history take your history. So mechanism of injury, history of present illness, or chief complaint. All right. So uncontrolled shock leads to death. If you don't do what you need to do quickly and right away, then your patient's going to die. Okay. Treating shock. So treatment depends on underlying cause. So if it's anaphylaxis, we're going to treat for anaphylaxis. If it's cardiogenic, they need ALS, they need fluids, they need various other things. And the best way to resolve hypoperfusion is to stop whatever's causing it. So that may require surgery. Trauma patients who have internal bleeding, they can't do anything in the field, they can't do anything in the ER, so it has to go to surgery. We're going to identify any kind of urgent interventions that may be needed and identify any kind of treatment needs as well. Okay, so we have this deadly triad of trauma. If one of these things occurs, then we have some problems, and the patient is not going to be able to fare very well in treatment, and they're not gonna do what they need to do. Okay, so acidosis, hypothermia, and coagulopathy. If the patient has any one of these three things, the patient's not going to fare very well, and they're spiraling. Okay. So how do we treat the deadly triad? So we're going to initiate transport to an appropriate destination. We're going to prevent hypoxia, prevent heat loss, consider shock positioning. It is now just laying the patient on their back flat and covering them with a blanket, giving them O2, and then we're going to consider advanced life support as well. Initiate transport to an appropriate destination. Manage the underlying cause. Manage the airway and breathing. Take steps to prevent heat loss. Patient in supine position, and request any kind of ALS. All right, so let's talk about bleeding. There are a couple different types of bleeding. Hemorrhage is severe bleeding. It may cause shock or hypoperfusion in trauma. You can have external or internal bleeding. You can have arterial bleeding, venous bleeding, or capillary bleeding, and these are all external bleedings. Okay. With external bleeding, it occurs outside the body after the force penetrates the skin and lacerates or destroys any kind of underlying blood vessels. Typically, it's visible on the surface of the skin, and how much they bleed depends on the size and severity of the wound, the size and pressure of the ruptured vessel, and the individual's ability to clot. If they have an arterial bleed, they're going to bleed out faster than if they have a capillary bleed. Okay. Venous bleeding is typically not a problem, although it can be. So arterial bleeding is bright red color, has a spurting with heartbeat, it's oxygen rich. Venous bleeding is darker in color than arterial bleeding. It has less pressure than arterial bleeding, and the volume of the blood carried by some veins can create immediately life-threatening hemorrhage. Okay. We could also have junctional hemorrhaging. This occurs in the appendages of the body that connect to the trunk. So like your armpits or the groin area. Those are your junctional areas. The arteries and veins are not well protected there, so they may have some bleeding there. And it's also likely to be massive. Bleeding can be accelerated by any kind of underlying condition. So if my patient is taking a blood thinner for AFib, then I need to know that they're on a blood thinner because they don't have the ability to form clots, their blood is thinner, and it's going to be much harder to stop. Okay. Hypothermia affects the body's ability to clot as well. So hypothermia doesn't necessarily lend itself well to that clotting ability in the body. External hemorrhage can be controlled by compressing the tissue around the wound. So use standard precautions. and wash your hands after each call. So we're going to identify and control any kind of massive hemorrhage within the first seconds of the primary assessment and ensure an open airway, ensure adequate breathing. Okay. You're going to control non-massive hemorrhage after assessing and treating any kind of prior elements. So be aware of the signs and symptoms of shock, and do not wait for the signs for the symptoms of shock to appear before beginning treatment. So methods, you can have direct pressure, hemostatic agents, wound packing, tourniquets, or specialized compression devices for junctional bleeding. It is essential to control bleeding to prevent shock. Okay, uncontrolled bleeding can lead to the patient's death. Standard precautions are mandatory, and you want to observe standard precautions and infection control practices when cleaning up. So direct pressure, we're going to apply firm pressure to the wound with the palm of your hand or fingers and hold pressure until bleeding is controlled. Resist the temptation to apply layers of absorbent dressing. If you can avoid it, don't just pile layers on top. Sometimes you have to. So once bleeding is controlled, bandage the dressing firmly in place to form a pressure dressing. So the difference between a dressing and a bandage, a dressing is like a 4x4 and a bandage is like Kerlix to wrap around it and hold it in place. And then we're not going to remove that dressing once it's been placed. Wound packing. So junctional areas present natural cavities that promote profuse bleeding. Direct pressure should be augmented by wound packing. We're going to fill the void spaces with hemostatic gauze as well. So with a pressure dressing, we're going to place several gauze pads on the wound, hold dressings in place with a self-adhering roller bandage wrapped tightly over the dressings and above and below the wound site. Create enough pressure to control the bleeding. Hemostatic agents, these have a clot medication basically on them that gets impregnated onto the gauze or dressing, and what it does is it helps the body create clots and stop the bleeding. Tourniquets, these will close off blood flow to and from the extremity. So use if the bleeding is uncontrollable by direct pressure. We're going to only use on extremity injuries and always apply between the wound and the heart. You're going to follow the manufacturer's instructions. Once applied, do not remove or loosen, and attach a notation to the patient alerting other providers that a tourniquet has been applied. When I was in the military, we did the T on forehead at the time, so that way we knew that there was a tourniquet on there. And there's a couple different types of tourniquets. There's the SWAT T, there's a ratchet type deal, there's the regular cat tourniquet, there's several others out there. Junctional tourniquets, so these are designed specifically to control hemorrhage in junctional areas of the axilla and groin. These things are great, but they're expensive. The one on the left side of your screen is a SAM tourniquet, SAM junctional tourniquet, and the other one is a clamps, ITC clamp or something like that. But basically it's a clamp, and it slides up underneath the body and gets pushed down, not directly on the wound, but on the artery itself. Elevation, so you can elevate the injured extremity above the level of the heart while applying direct pressure. Do not elevate if the patient has any kind of musculoskeletal injury, impaled object, or spinal injury is suspected. Splinting. This can be used to control bleeding some. We're going to stabilize the sharp ends of the broken bones. You can use inflatable air splints. You can use SAM splints. You can use lots of different things. Cold application. So this minimizes swelling, constricts the blood vessels, and reduces pain when it's used in conjunction with other manual techniques. Head injuries. So this may be from an increased intracranial pressure and not direct trauma to the ears or nose. We want to stop bleeding only. Stopping the bleeding only increases intracranial pressure. So with head injuries, we do want them to bleed just a little bit, just so that way it can come out. Because inside the head, when we talk about head injuries later on, head injuries only have so much, or the cranium only has so much room inside the head. And there's what's called the Kelly-Monroe doctrine that basically says that you have so much percentage of brain, so much percentage of cerebral spinal fluid, and so much percentage of blood. So if there's bleeding inside the brain, that bleeding has to go somewhere if it's not coming out, and it has to go into the brain or take up space into the cerebral spinal fluid. So we want to allow the drainage to flow freely using a gauze pad to collect it. If it's not bleeding from inside the brain or like intracranial bleeding or anything like that, and it's just like a scalp, then yeah, we can control it and stop the bleeding. Nosebleeds, epistaxis. I guarantee you will see that word on a test. Guaranteed. So you're going to have the patient sit and lean forward, apply direct pressure to the fleshy portion of the nostrils, keep the patient calm and quiet, do not let them lean back, and if the patient does become unconscious, we're going to place them in a recovery position and be prepared to suction. I have had some wicked nosebleeds, not myself, but patients who have had wicked nosebleeds. These can be almost dang near impossible to stop. The ER has something called a rhino rocket. Basically what it is it gets shoved up into the nose, kind of like a tampon, and gets placed up there and it stops the bleeding. There's also what they can do is cauterize it. So they can take kind of like a heat needle and cauterize the wound and stop the bleeding that way. So there's a couple different options, but the rhino rocket works pretty good. So we're going to begin hemorrhage control with direct pressure. Consider a hemostatic agent. Consider the need for wound packing. Consider a junctional tourniquet if you have one. If all of that fails, then we're going to apply a tourniquet. Okay. Here's the caveat to that. If you've got direct pressure and it's not stopping, put a tourniquet on. Okay. Skip everything else. Just put a tourniquet on if you can put a tourniquet on. We used to say that there was like 3 hours max for a tourniquet, and then it moved to 6, and then it moved to 18, and then yeah, you can have a tourniquet on up to, I believe, 72 hours before anything major starts to happen. Now, are we going to have a tourniquet on for 72 hours? No. Okay. That patient's never going to have a tourniquet on for 72 hours. But apply that tourniquet. Don't be afraid to use the tourniquet. Even if it's just, if you can't control the bleeding, you put a bandage on and you put dressing on and you put dressing on top of that, and it still continues to bleed through all of that, then, and it's not like spurting, but it's still bleeding, yeah, you're going to have to, put some tourniquet on because they're going to have to control that bleeding. Internal bleeding, so this is damage to the organs and large blood vessels. This can result in a loss of a large quantity of blood in a very short time frame. Blood loss is commonly not seen, um, and severe blood loss can result from injuries or injuries to extremities. So this guy had some type of bleeding in his abdomen, guaranteed. Okay. Mechanisms of blunt trauma that can cause internal bleeding, such as falls, motor vehicle crashes, auto pedestrian collisions, and blast injuries as well. Gunshot wounds, stab wounds, and impaled objects can all cause internal bleeding. And these may not cause a whole lot of external bleeding, because if it's an impaled object, that impaled object is actually what's stopping the bleeding from coming out. And it may also be stopping the bleeding from going anywhere else inside the body, but when you remove it, that's when it's going to start bleeding. So some signs of internal bleeding include injuries to the surface of the body, bruising, swelling, tenderness, painful, swollen, or deformed extremities, and bleeding from the mouth, rectum, or vagina. Alright, so signs of internal bleeding. So tender, rigid, or distended abdomen. They'll have that coffee ground emesis, or it may be a frank, bright red blood. They may have some dark tarry stools or bright red stool, and they may also have some signs and symptoms of shock. You want to maintain your ABCs, consider high flow O2, control any external bleeding, apply a splint, take steps to preserve body temperature, and provide prompt transport. All right. As always, if you have any questions, let me know, and I will answer those questions, or I'll find you an answer.